right, well, we're glad to see you here this morning. I'm talking about trauma-informed care just from the standpoint to make sure that we all have the same framework for the morning. Trauma-informed care is, I had to do a little research on this, and I am indebted to Siki Hu, who's our research assistant for the center this year. She helped pull together these slides, so she did great work, and I appreciate that very much. The National Comorbidity Survey, which is data from 1990 to 1992 in the U.S., says that the prevalence of trauma exposure among respondents in the survey who were age 15 to 54 was that for men, at least 60% had had one traumatic event in their lifetime, and 51% of women had had at least one traumatic event in their lifetime. And the combination of the type of event and the impact of the event is such that, and the response is such that women are 2.5 times more likely to have PTSD symptoms as a result of that traumatic event. What we know about trauma is that from the Adverse Childhood Experiences Survey is that the more you accumulate events, the more health outcomes there are for you. So in the ACEs study, you can see on this figure, the gold and the yellow are fewer numbers of events, and the darker it gets into the green, the more number of events there are. And when we look at the low end, what we start to see are some health outcomes that are adverse. So obesity, diabetes, depression, suicide attempts, and then some chronic diseases, heart disease, cancer, stroke, COPD, those kinds of things. As we move along this spectrum of dose, the outcomes, the behaviors that we see start to increase that will enhance the likelihood of having an adverse health outcome. So we start seeing behaviors that can be detrimental to health, such as excessive smoking, alcoholism, and drug use. And then we get on the far side of this graph at 5 or more ACEs, and the life potential starts to be impacted. So graduation rates decrease, people have more time off from work, which impacts their ability to move forward in their career and has adverse effects on not only their professional life, but also things like their income, which we know has an association with health outcomes. This is work that's been done by RYSE, which is a group that looks at in New York City and then has offices spread across other parts of the country. And they've taken the adverse childhood experiences triangle on the left, okay, and they've added a couple of levels to it. And they've said, in addition to the base of the pyramid, which is the adverse childhood experiences, and then as you move up, it goes into those adverse outcomes that I talked about on the last slide, that beneath all of that, there are also some social things that occur, so social conditions and generational impacts that get shared. So the way people view their world because of the environment that their families have experienced. And so they've added those couple of levels of things we need to think about in terms of what people might experience as trauma. So the kinds of things that we see after trauma are listed here, and basically people oftentimes initially have difficulty coming to terms with the fact that a trauma has happened, and they have sadness and helplessness and guilt and those kinds of emotions that accompany it, all of which make it more difficult to get the kind of care that they need to overcome the impacts of the trauma. And so this idea of trauma-informed care that we're talking about today is about addressing many of these kinds of emotions that people experience in order to make it more inviting for them to seek the care that they need. I wanted to just briefly touch on the kinds of things that make it worse for clients, things that we might do that could have negative impacts. So what we're finding is that if you have to keep telling your story over and over, that's actually not helpful in the healing process. So there are some other ways that we might think about how treatment rolls out. People really need to have a personal relationship in this healing relationship and not be thought of as, one of hundreds or thousands in a practice or agency that are dealing with this kind of trauma. So we'll talk about some of those, and you can sort of read through these. But if we do the things that are on this list, they actually can lead to re-traumatization. And so these are behaviors that we want to avoid and insert in place of them other behaviors that will help to avoid this potential of having re-traumatization. What happens if someone's re-traumatized? Their ability to have trust in the person that they're working with will go down. In terms of health impacts, we see more self-injury. They're less willing to come to treatment. They'll have an increase in the kinds of symptoms that we've been talking about. And we'll see more chronic stress, which can lead to psychiatric illness, such as PTSD or chronic depression. We see hospitalization go up, and symptom relapse. So enter trauma-informed care. The goals of trauma-informed care are to take a standpoint that every patient who walks through the door has had a trauma, and you just need to begin from that place, and rather than sort of delving to find out, we just have a practice that recognizes that trauma is common, and that's how we need to approach our interactions. We also want to have sort of an operational and structural way of responding such that we have responses to trauma and implement the kinds of interactions we want around trauma that will be supportive of the person who's had trauma and avoid re-traumatization. And then recognize that on both sides of this equation, both the client or patient and the therapist or the person who's working in a program need to have physical, psychological, and emotional safety. So that's an environment we want to set up for both sides. These come from the State University in New York, so SUNY Buffalo. 5 principles of trauma-informed care, and these are the 5 we're going to focus on today, and depending on whose work you look at, the number of principles changes, okay? This is one example, and so this is the one we're using today. But the principles are safety, choice, collaboration, trustworthiness, and empowerment. And so these are things to strive for in this relationship, and again, it's for both parties in the relationship that we're working. And I want to sort of close with what you can expect from the literature. Here's what we see as outcomes associated with implementing these 5 principles. So if you have safety in the programming that you're doing, clients are better able to manage anxiety, they increase their autonomy, they prevent future trauma, for example, okay? Choice leads to increased autonomy and being able to regain control in their life, and it cultivates their self-advocacy and so forth. And so you can take a look at this, and this is we're fairly early on in the research about this, and with regard to refugees and immigrants, we're very, very early on. So there's very little research out there right now on these populations, which is, these are groups that the center focuses on in particular. And so much of the evidence that you'll see comes from other populations. Homelessness, youth, so those kinds of populations, and yet what we read in the literature sounds a lot like what we deal with in the refugee and migrant populations, and so we expect that these will have the same kinds of impact. All right, that's my blurb that we're all on the same page, okay? Let me just introduce to you Dr. Im, who's our guest today. We had a community advisory council meeting a few months ago, and in sort of planning for what needed to happen in this coming year for the center, one of the things that came out very clearly from our community partners is that we need to be talking about trauma-informed care. And so Dr. Frost and I went back and said, sure, yeah, let's do that, and said, who would that be? And we started Googling. And the name we came up with, and it didn't take very long for us to get there, was Dr. Hyojin Im. We're so thrilled that she has decided to come here and talk with us today. We've had great interactions with her so far. She's been to classes, she's been talking with researchers and clinicians, and we're looking forward to a really productive relationship going forward. But she has done her work with a lot of refugee populations, so some internationally and some domestically. We're really excited that she's going to be able to talk to us a little bit about this, but she has background in psychology and social work and political interactions. She has this wealth of experience, so she's going to bring all of that together for us today and talk about her research. So Dr. Im, we want to welcome you today. We're so glad to have you. Come on up.
Thank you so much for the generous words and the wonderful introduction of the trauma-informed care. So thank you so much again for having me. Oh, yes. Yeah. Okay. Start.
Her on this? Are we good?
Okay, both or just one?
I don't know.
Okay, I'll just try to use one. Okay.
And that can go in a pocket or something if you
Okay,
want to.
okay, good. Thank you. Okay. Thank you so much for coming. Good morning. Good morning. So thank you again for Dr. Well, I'm feeling more comfortable calling people by name. So thank you for Lisa and Karen for giving me a privilege to talk to you this morning. I was so fortunate to be found, and my work hasn't been really long time because, as Lisa briefly mentioned.
I'm going to turn you up a little bit.
Oh, okay,
It's
higher.
just so quiet.
Okay, my voice.
No, I think it's the speakers there. Okay, I think we're good.
Thank you. No, it's okay. Well, I have to kind of thank first. So I really thank you for the Delva and Creamly families for organizing this wonderful symposium. So I'm so honored to be here. I think this symposium and today's topic really speaks to, I'm sorry. So I actually didn't want to move this. So I just wanted to mention that I think this symposium and today's topic really speaks to the importance and the recognition of the trauma-informed care that has been well accepted and applied in many fields and disciplines, including healthcare, social services, child welfare, school system, and just general social work practice field as well. It's particularly important to apply a trauma lens to refugee and immigrant population in particular, who are most afflicted by the tremendous trauma, but those trauma has been less attended or untreated during the migration, and also even during their settlement in the U.S. So I think this is important to really talk about it. But it's not really until recent years that trauma-informed care is explicitly discussed in the refugee and immigrant population in specific, which is quite surprising and strange even, given the immense needs and applicability of this approach to this population. Despite that, I believe many practitioners and faculty members and students here in this room perhaps have been practicing some form of trauma-informed care practice with this population without even knowing the term or not using that, the principles that are articulated in this approach. So again, I feel so humbled actually to share some of my work. Mostly actually it's a refugee. So even if I said that refugee population, I believe that the contents are still relevant to the immigrant population that you are working with. So I'd love to talk more with you after this talk and hear your experiences in the field and your kind of questions or any insights about this topic later. So, let's start. So Sorry, I'm clumsy in technology. So I'm actually skipping a few slides because Lisa actually introduced the trauma-informed care so wonderfully. So I actually use some of the diagram to, it happened to be the same here. So I want to start with the actual refugee population first. So refugee communities experience a tremendous trauma before, during, and after migration. So can you see this, the contents well? I mean, this is really squeezed. I actually expanded, and couldn't expand more, so I kind of stopped it. Because you can actually feel more kinds of trauma, but these are some common forms of trauma. So according to a statistic, I mean, I have to say that actually there's a very low kind of prevalence study about refugee trauma, partially because of it really depends on the context and the timing of assessment. But according to some statistics done by the Center for Victims of Torture, about 37 to 62% of refugees experienced being close to death, and 37 to 54% experienced torture. 35% witnessed the killing of their family members. 2/3 of refugees experienced a lack of water and food for a while. And other types of trauma are so common, but it's hard to detect or underreported, such as sexual and gender-based violence, human trafficking, and multiple forms of human rights violation. So we have actually many studies about the refugee mental disorders as a consequences of trauma. So the refugee population have a high risk of developing common mental disorders such as PTSD, depression, anxiety, and other somatic symptoms. One review study with the 180 surveys from 40 different countries, refugees from 40 different countries, showed that almost 30% of refugees experience PTSD or depression. And CDC study with the ORR, Office of Refugee Resettlement, the 16 cases of Bhutanese refugee suicide, which was between 2009 and 2012, which is 3 times higher than general population in the US. And also the trauma really has a lingering impact on mental health. So for example, Cambodian refugees who lived in the US for more than 2 decades still showed high rates of PTSD and depression, like 62% of PTSD, 51% of depression because of the pre-migration trauma in the home country. So trauma-informed care seems like it should be applied to these populations. The trauma is maybe the only standing word to explain and express the refugee challenges. But it may surprise you to find out that there are really few studies really conducted on refugee-informed care, trauma-informed care with the refugee population in specific. Perhaps, it's my guess, but perhaps one reason for that is consequences of trauma are universal human experience. And our social services and many community programs do not necessarily focus on the certain types of trauma, like war trauma or some trauma from social conflicts that are very unique and common to refugee population. Another reason, I think, oops, sorry, again. Another reason I think is related to the strong history of refugee trauma treatment practice in the past. So when you look at the trauma and refugee population, the most things that you can actually easily access to is about trauma focus, the cognitive behavior therapy, narrative exposure therapy, EMDR, those kind of a trauma-specific or trauma-focused interventions, not trauma-informed care. So research on trauma, refugee trauma in particular, is really based on human rights movement, which is slightly different from the typical trauma-informed care that we know based on the ACEs study, like adverse childhood experiences, which is based on the feminist movement and also child rights advocacy groups in 1980s, versus refugee trauma studies really based on the human rights movement and anti-war activism around 1970s. And finally, 1981, Harvard program in refugee trauma was founded by doctors Molika and Redlick, who helped the Southeastern Asian refugee population who were suffering from war trauma. So this center actually has been really in a key role in refugee trauma studies, and they actually developed a Harvard trauma questionnaire and Hopkins symptom checklist. Those are the main kind of the tools to assess PTSD and depression. And until now, when we look at refugee trauma consequences, we really mostly focus on the PTSD and depression because of that tradition. And after Victims of Crime Act in 1984, finally we established Center for Victims of Torture, which is a leading organization in the field of refugee mental health. So as you can see, because of those background, more trauma-specific programs we can see in the refugee services, but a few studies have been done on trauma, the effect of trauma on health or wellness and other service area issues. So I would have to say there are some unique needs that should be addressed and considered in trauma-informed care for refugee population in specific, and also immigrant population perhaps. The first thing is the role of culture in trauma. And the second one is the nature of the trauma, so the complexity of trauma experiences in this population. And the third one I would say is barriers to systems. So I will go through each topic one by one. So first, the role of culture in trauma is immense in immigrant and refugee population. Interaction of trauma and culture is very important because every and each aspect of trauma experiences are filtered through a person's cultural value, belief, background, norm, and practice. But culture is not just a personal background or unique background of an individual, but also is a collective reality constructed, shared, and practiced by a certain group of people with the same history and customs. So when you look at the trauma, how trauma is experienced and how trauma-related symptoms are expressed and addressed is all depend on the cultural practice and beliefs. But non-Western or non-native way of trauma responses or coping are often unattended or underserved in our system. So culturally responsive and relevant assessment service options are really not well arranged in our system. So these lists that you see in the slide is some of the cross-cutting factors that we need to consider when applying trauma-informed care to this population. These are only some of the list. As you can see, religion, language, geographic location, whether they're from rural or urban area, their worldview, value, tradition, how they perceive the health and illness, and family, kinship relationship, gender roles, sexuality, and so many things that play a critical role in trauma experiences and trauma expressions. So one thing that I also wanted to highlight for this population is the high stigma around the trauma. So some settings are more safe, or the settings are kind kind of more open to discuss the trauma. But no matter how you kind of provided some safety and kind of the sense of the community, sometimes the refugee community itself has a lot of stigma around the trauma, and also the a certain kind of gender expectation and belief system really doesn't allow them to speak up about their trauma. So high stigma around the trauma and mental health symptoms are really striking in this population even more so, partially because they really are afraid of reopen the wound and re-traumatization to oneself and their family. Because sometimes when they're talking about their traumatic experiences, people believe that brings shame to their family as well. And the concept of mental health doesn't really exist in many cultures, many other cultures outside of Western countries. So mental health means mental illness, and that means a craziness. So concept of mental health services also doesn't exist. Counseling oftentimes in other countries means just problem solving or advising. And also a lot of refugees I work with had a very little concept or experience with the formal services, like healthcare, healthcare settings, or just any formal social services. Even if they had some, oftentimes they are very negative experiences. So I wanted to share some quote from a Hmong woman who I interviewed in Minnesota. She shared a story about her cousin. So she mentioned that one of the fear of living in the Thai camp was seeking medical services from hospitals. My uncle, who had taken his daughter to the hospital, which was the only time you can leave the camp, and brought her back dead a couple days later. She couldn't have died. She only had a bad headache. I didn't put here, but she also added that Thai doctors, she thought that Thai doctors must have killed her for her organs or blood. And she said, you will never know. So I don't know if that was really true, but that is kind of common sense that people had in the refugee camps or other settings where they had a very limited resources and protection when they access to healthcare or even any other kind of social services. Because of that, refugees really deal with their trauma consequences just doing almost nothing, just to suffer in silence. Sometimes they do self-medication, like a substance abuse, calling self-treatment. Sometimes they internalize their anger and do self-harm. And another common actually coping is sending people with issues back to home country or other countries. Chaining, I've seen many cases, people just hide the problematic person or person who is suffering from trauma at home, or they are relying on sometimes traditional healing method that sometimes it's empowering, sometimes it's not, depending on the kinds. Some are like just religious coping that doesn't bring much harm. Actually, it sometimes empower the community, but sometimes they are doing so many different method. So one crazy thing I've seen was a hyena. So some other culture has a belief about evil eyes. When you get caught by evil eyes, somebody can get crazy. Of course, it's because of their trauma experiences and other kind of challenges in the life. But people just believe that they are, they have evil eyes, so they put a person in a hyena cage, so that the hyena can look at the person's eyes that will expel the evil eyes. So that is one just example that I've seen, but one of the many actually some unsafe kind of practices I've seen in other countries. So obviously, different cultures have a different expressions of trauma experiences and their suffering. Some cultures said my heart is upside down. Some says I have too much air in the brain. These are very common expressions in some cultures. And thinking too much, it's a very universal actually. And feeling like a stone or possessed by evil spirit or jinn. Feeling pain all over that I cannot express, that cannot be expressed. So some culture, actually most culture has their own way to express those emotional suffering because of trauma. We call that cultural concept of distress. So that is a very useful kind of concept to avoid the stigma and understand the culturally appropriate coping and healing process in the community. I don't want you to, I didn't mean you to just read all these small letters, but I just wanted to show you one example. I work with the Somali community a lot, and this is one of the work that I've done. None of the words in bold you can recognize perhaps because these are Somali language. But at the bottom, muruk, for example, M-U-R-U-G at the bottom, that is a sorrow. Or you can maybe translate that into a depression. So these are not like pathologizing kind of term or medical term that Westerners use, but the local people have very similar term, like alternative term to use to express their own feeling. And that way actually people feel more safe to express their suffering. So there are some languages, and I just wanted to actually show you these because you perhaps noticed that only one thing that says jin is not like kind of circle shape. That is actually more cross, sectional. Like it's across the other circles, partially because people feel most safe to say that it's caused by something else. It's not my problem, but it's caused by, some evil spirit or outside power. So the possessed by jinn means that I act very weirdly, but it's not because of me. The external or spiritual kind of power make me doing that. And also, being possessed jinn has the very kind of obvious solution for the community. They can simply just read the Quran and then read the the religious book, and then people will kind of get cured, treated. So jinn is almost the only idiom in this community that has a known solution. So people express their symptoms just using that term a lot. That's why you see the jinn symptoms are all over, versus others are very clustered and segregated. Another issue that the complexity, trauma-related issue in this community is that people typically experience very different types of trauma, which is universal to refugees and immigrants. Migration itself brings some trauma to this population. So I met a lot of people actually expressed their frustration because of the gaps between their reality and the expectation. So one woman actually mentioned that I was one of those people who thought in the US there were walls where you just withdraw money. Instead of money, I received an abundance of snow. It was in Minnesota. So I met so many people expressing the frustration and how much they are not ready to cope with this adjustment process because of the unrealistic expectation for the resettlement, which is a very understandable because only less than 1% of refugees in the world get resettlement. So it's almost like a lottery for them. And also, post-migration trauma is sometimes not very well attended, but it's very obvious. It is natural for refugees and immigrants to compare home country culture to local culture. However, this may lead to more stress and cultural stress. And also changes in social status when they come to the U.S. Maybe some of them were doctor in the home country, but in the U.S. they are working in the farms or meat factory, and there are changes in social status and family roles. Oftentimes, children and women get more well adjusted, and men kind of are losing their own power. That kind of sometimes lead to domestic violence or more family conflicts. And also intergenerational gap, you definitely understand this a lot because of the children catching up faster than the adults, even elders. Elders are actually oftentimes have never had a chance to actually learn or master English. Loss of cultural practice, identity crisis, in addition, on the top of that, they still face the discrimination and poverty and family separation and social isolation. And all these things are created by just the migration experience. So traumatic stress actually continues after their resettlement. Some study shows that the pre-migration trauma is more kind of harmful to their mental health. But some other studies actually say different. So more devastating impact of post-migration stressors than pre-migration stress because of all these challenges that I just showed you in the previous slides. But I want to just say that each migration stage, including resettlement, has a cumulative negative effect on mental health, no matter what. The third one, system, barriers to system. I have to really say that because we didn't really see much trauma-informed care practiced in our system. One reason I mentioned earlier was because of the universe experience, but also another thing I believe is because of accessibility issue. Refugees oftentimes have some mental health problems, but way lower number of people can access to the needed services. The reason is very obvious: language, culture barriers, transportation, lack of information or cultural orientation, even different perception, different belief system, and limited resources or systems for adequate assessment or care of trauma-related needs, from screening to referrals and to treatment and recovery, and also lack of awareness and capacity for culturally responsive services that are trauma-informed. And also high stigma and lack of awareness around trauma in the refugee community also hinder the help seeking. Another issue that also I wanted to mention is communication breakdown between the service providers and the refugee community. And also trust issue. As you saw in the Thai camp, the woman's kind of experience, a lot of people have very negative kind of experiences with the law enforcement, social service providers, and government mostly in the past that is still kind of influencing their relationship currently with the community providers here. So I wanted to show you a couple different models that kind of examples of a trauma-informed care for refugee population. So trauma-informed care can be applied to both individual organization or program and to entire system of care. So when refugees arrive in the U.S., they need multiple intersectoral services, from housing to employment to school to healthcare, you just name it. Building a trauma-informed care for newcomers takes an entire community and a system. So in terms of mental health and psychosocial needs, refugee needs are varied. So that's why we wanted to build some multi-tiered model on the left for the system level. And also there's a program level kind of intervention that is grounded to community. So I want to show you the system level, how trauma-informed care can be applied to system level intervention. So I work quite a bit in different international settings, and there is WHO and interagency standing committee developed some guideline for mental health and psychosocial support in emergency setting, humanitarian emergency setting. It was 2007, so it's a bit old, but this has been practiced in so many post-disaster or post-conflict settings. When disaster or conflict happen, the community actually experience multiple different needs, right? First thing you can imagine is water, food, shelter, and protection and safety, right? But also, sometimes they need a more support around their community building and kind of family relationship. Because the disaster or conflicts affect the family, and the family bonding or relationships kind of can change it. But sometimes also the trauma affects individual more deeply, so that individual develop more mental health issues, like common mental disorders, for example. Or sometimes the entire affected community increased risk for even severe mental illness for the community. So this pyramid model actually shows the different needs. These are kind of concurrent care system that are comprised of 4 tiers based on the concept of triage matched with the level of distress. So as you can see, the bottom is for everyone. It's a social considerations and basic services and security. It is required for almost everybody, the entire population. So tier 1, the bottom program is typically to provide basic services and security, such as food and shelter for protection and advocacy. The tier 2, which is the second to the bottom, is for community and family supports, which facilitate coping among afflicted individuals and promote well-being. And the tier 3, the second from the top, is a more like focused, non-specialized supports. It can be kind of trauma-focused intervention like a CBT or kind of the therapy done by sometimes professionals, sometimes trained paraprofessionals. And the top one, specialized services, is for really the people who have psychiatric mental health issues. So this is the international model. This is not what I developed, but this is an international model, international guideline. So I thought that this can be also applicable to domestic setting. So the bottom part, the older refugee population would need some kind of support for adjustment in the US, right? And then second part is more about psychological functioning and then strengthening the community and family. And then third one, second from the top, is more about addressing trauma-related mental health issues. And the top is, again, the very severe mental illness, which is a very relatively small portion of the population. So this pyramid model was applied, well, on the left. You can see the very narrow pyramid on the left side. So I put that here in the refugee resettlement context so that these can kind of guide our the state program. I work with the Virginia state, and right now actually with the Kentucky and Texas as well, and we kind of try to adapt this model to provide trauma-informed care at system level. So this kind of framework give us some idea of how to put resources and where we can actually work together and that kind of planning. I don't know if I can enlarge a little bit. Okay, is it better? Okay. Refugees have a very differential mental health needs that can be detected during initial health screening. I don't know how many of you are aware of that, but the refugees, once they come to the United States, they're required to go through physical screening, right? But nowadays, we also added mental health screening, which is completely voluntary. Not many people really sign up for it. Sometimes there's a rumor and also stigma. So not many people will actually do it, but still we ask them whether they are willing to take mental health screening. So we provide a mental health screening. Depending on their scores, we can perhaps screen at the beginning their mental health needs. So the screener name is Refugee Health Screener, RHS 15, because it has 15 items. So the bottom part, as you can see, actually their cutoff point is 12. So when somebody RHS 15, the screener point is 12 or more, they are actually will refer to some mental health services. Of course, it's voluntary. Some people just decline to go, but we still offer those referrers. And the tier 1 and tier 2, we don't need perhaps that kind of screening, or the screener point doesn't matter. We need to just provide any just basic services that refugees need to make sure that they are socially well adjusted to new country. So the tier 1 at the bottom is, I can show actually this way. I can explain one by one. So tier 1 includes refugee services to support just adjustment and integration, which includes refugee reception and placement, we used to call them ROLAG, right? Refugee Resettlement Agencies, services like case management, ESL classes, vocational training, and cultural orientation, and many more, maybe public transportation, and also the housing and any other social services that the refugees may interact with. That can be the target of these services at the tier 1 level. And focal capacity for tier 1 is recognition of unique psychosocial needs of refugees because of the trauma. So the agencies are informed by trauma, and then they realize and recognize the trauma impact in this population, and then they can provide relevant related services to them or refer them to the right resources. So that is creating the trauma-informed care for those agencies. That is the goal of the tier 1 services. Tier 2 is more focused, but not necessarily through systems. It's more focusing on the building healthy coping and support systems in the refugee families and communities, typically through community-based interventions or programs, like support groups, or I can actually introduce you a few examples later. So some kind of community programs can help refugees to rebuild and restore their relationship and community sense. So since I'm going to show you more examples around that, so I can just move on. Oh, actually I have to mention this. As you can see, the stress coping and functioning, and then I said these one for mental health needs are not really high. So refugees are typically just below the cutoff point, meaning that they're negative. So it shows that actually basically they don't have any urgent mental health needs. But I think oftentimes still we need to provide some psychosocial support, especially mental health related support to these group as well, because screening is not always implemented. As I said before, refugees sometimes decline. So for example, one of the resettlement sites in Virginia, only 30% of refugees take the mental health screening. The rest of them just refuse, which is not very unusual. And also, the timing of screening is a bit too early. When refugees come to the U.S., they have to finish their physical health checkup along with the mental health screening before almost 30 days, which is too early for so many people to express their needs. And also screening procedures are through interpretation, oftentimes, and lack of trust and relationship with the professionals obstruct the voluntary screening. And also lack of cultural sensitivity and capacity of the people who are implementing it, so make people uncomfortable and sometimes just hinder the detection, identification of the needs as well. Tier 3 is more system level. These are more through mental health care providers or healthcare settings. Tier 3, both actually 3 and 4 are the kind of system level. But again, I have to say refugees often cannot access those services. That's why we need to work with the community level to make sure that they can get informed about the available services and also can access to those resources. So Tier 3 is designed for targeted groups with trauma-related mental disorders, like common mental disorders. Through maybe you can identify their needs through early screening, like those whose score is over 12. But oftentimes you can actually find them through other services referrers, rather than just the screening alone. And then Tier 4 is very specialized care, but for better kind of integration and recovery in the community level, we can maybe pursue the integrated care and so embedding the mental health components to primary care setting where refugees can more easily access to. So this is the kind of model that has been guiding our practice in Virginia State. And this kind of help people to understand where they are and then how they can build kind of the referral systems among them. I'm going to show you some of the community-based intervention, which was a Tier 2. We call it a trauma-informed wellness program. We never use mental health or trauma even. Sometimes with trauma, we have to kind of put that in the maybe context or in the text, the curriculum. But we often say this is not about mental health treatment, and also mental health automatically kind of it's a red flag, right? People just will think that this is maybe some treatment kind of program. So some people maybe kind of sign up for that, but most of people will be scared off and then they just go away. So trauma-informed wellness program was actually 2-tier model, but I added the third one, which is a sustainability. I think that's really important for the community level intervention. So it always starts with the capacity building. Oftentimes people don't understand the trauma-informed care clearly, or sometimes they understand trauma, but they didn't really link the trauma impact with all the trauma experiences they had. So capacity building is not only for the service providers, but also the community members and leaders who can help this healing process. And then intervention is often I took peer-based intervention model so that trained community leaders can provide some wellness program to their own community members. But sometimes I think agency-based one also works well, so I can show 2 different models. So in Virginia, I had 2 different location used a different model. So one in Richmond, it was peer-based model. So I provided all the training to refugee community leaders, and they provided intervention to their own community member. In Charlottesville, I provided some training to both community leaders and providers together. It's more interactive training. And then we put the program in the agency through the resettlement agency and refugee serving community-based organization. It was actually a gardening program, so it was perfect for us to add some wellness content to them. And then after that, the third circle for both is more like a sustainable kind of plan. So after we finish those interventions, people still stay as a group to continue working together on some other topics and some other issues. So training was trauma-informed, and it's cross-cultural. Ideally, I want to continue this as a form of interactive training among the leaders, community volunteers, and also the service providers who are either mental health professionals or not, whoever served the refugee community directly one-on-one or as a group, so that they can understand the trauma impact in this community, and they can be the kind of first responder to the community issues. So the contents were basically, basic psychoeducation, the refugee trauma, the impact of trauma, not only on mental health, but relationships, spirituality, behavior, community level. All these contents are in here, so it's very trauma-informed and also cross-cultural, so that the providers can learn cultural expressions and cultural ways of coping from community leaders directly, and then community leaders can learn from professionals about the skills and resources as well. So this is one of our group, actually third trauma-informed care training group. As you can see, they are very diverse. A mixed cohort of refugee, immigrant community leaders. Actually, we have quite a few Latina female leaders as well, and professionals from healthcare setting, and also the resettlement agencies, IRC, in this case is Charlottesville. So it actually provided a chance for us to empower the community and grow some leadership in the community too. So after this training, leaders became a mentor to their own community, so that they can provide not just the interpretation, but they can also provide some wellness content, and they can educate and kind of help the community members as well. So this is kind of the rough kind of the idea of cross-cultural capacity building. So mental health knowledge and skills can be provided by mental health professionals who understand trauma-informed care very well, can be there, but also we need different kind of people's inputs and insights to inform them about how culturally distinctive this community can be, and how culturally, how we can build a culturally more relevant services to the community. So cultural insights from the refugee community and refugee service experiences from resettlement agencies, those are not necessarily mental health providers. So all together sit in the same room. Typically the size is between 10 and 20, and then they talk about all these contents. It's a manualized intervention curriculum, so they actually learn each topic, but also have a lot of rich discussion about how community is actually handling. So that way, they not only just build the capacity, but also build a relationship and partnership for healing process. Intervention, we never use mental health in this case, because it's a targeting refugee community members. What we provide is a more holistic kind of approach and preventive health as well. So we start with body health, healthy eating. People love to talk about how their eating changed after resettlement or migration. As you perhaps well know, the obesity, diabetes, and heart disease, a lot of health issues immigrant and refugee communities are suffering from is related to that kind of the lifestyle change after migration. So we talk about those topics, and then we talk about how stress can affect the body, so that way we can link the body symptoms to stress and emotional suffering. And then we start talking about stress and trauma impact. And people will more open up around that time, because it's a closed group. It's a kind of cohort intervention. So they have already relationship built within the group, feel more comfortable sharing their own experiences. And then we talk about the healthy coping. We teach them about mindfulness, breathing, exercise, so basic kind of psychoeducation curriculum. Again, this is also manualized curriculum, so I developed that based on the psychoeducation curriculum from Center of Victims of Torture, but I also added nutrition toolkit from USCRI, which is the U.S. Committee for Refugees and Immigrants in D.C. So they developed some nutrition toolkit. So I kind of combined those two in one and make it into 8-session program. So we meet once a week and typically for 2 months. So the findings are actually really amazing. I mean, I'm not saying because it's something that I found, but I would say sometimes we kind of targeting just building health knowledge or wellness skills. People really just build the social capital immediately. Bonding or linking or bridging, they just immediately get connected to their other community members, and then they provide instrumental and emotional support. So there is so much kind of actually rich information in some of them, but I can definitely share more later. This is our agency-based model, so it wasn't peer-based, but this one we actually embed the wellness workshop to the existing program in one of the small community organization. That was a container gardening. So they have very small space. People usually cannot access to large kind of spot. So we taught them about container gardening, and then we kind of used the gardening skill as a kind of metaphor for healing and growth. So people said together we learned about the container gardening, nutrition, and healing. So that's very actually beautiful. And then we kind of try to build the wellness through empowerment. A lot of people just experience that. I mean, oftentimes people think that people don't know this kind of information, and people have very low literacy and so on. But actually, when we started talking about the contents, people have very critical understanding of 2 different cultures, and they increase self-efficacy and confidence through this open discussion, through the group process. And also building relationship and the community so that they can collectively solve some community issues together. I spent a lot of time, so I just want to kind of slowly wrapping up. So resilience. Maybe this model kind of look familiar to many of you. This is actually resettlement or acculturation process, right? So starting with the honeymoon stage, and then feel frustrated when you find the reality, and you start getting more adjusted and getting recovered and find the balance, which we call adaptation, which it very looks similar to resilience, right? So resilience is the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress. So bouncing back from difficult experiences is resilience. Resilience is it's an ordinary process, not extraordinary. And people commonly demonstrate resilience at some point. So this is what we want to build through the community-based interventions and trauma-informed care, and mostly healing partnership. So trauma-informed care is not to build not only resilience skills, but also create and restore a space and a relationship with individuals, families, and the community for healing and recovery. So building a partnership among compassionate community members and providers help enhance the community's capacity to address numerous challenges or trauma impacts that refugee and immigrant communities face when making a new home, when they are making a new home in the United States. So this is what I have so far, but I'd love to hear your thoughts and any questions later. Okay. Thank you. Or I'd love to hear your experiences in the community as well. But
With your research, how have you taken your community efforts to have the balance and the workshops and the sessions? And I saw that you had childcare with a safe environment there. Do the children get at all involved in these sessions, and what does that look like?
yeah, that's a great question. So I can give you some examples, actually, particularly this group. So we had a Congolese and African group. African group was all women because, I mean, we didn't intend it, but I think that's more culturally appropriate. And so we had 12 women, 15 children. So we had 5 volunteers who did childcare in the next room. The place we met was not in the agency because of the transportation and the sense of safety. So we actually went to their home. The African community in that case, they are living very close to each other in the same apartment complex. So we found one house for childcare and then another house for the intervention. So women actually sit together and then we provided intervention together. So yeah, child wasn't involved because the contents are, I mean, still it's their kind of conversation about their family and, you know, their concerns. So yes, it's a separated. Is it? Yes.
With that intervention, was it led and facilitated
Facilitated.
by a mental health professional and community leaders? So you talk a lot about peer-to-peer.
Mm-hmm. Yes. Yeah.
My question is if there is a mental health professional facilitating as well as the peers and the other.
Yes. Yes. So, trauma-informed training, cross-cultural training, we actually we definitely need the mental health professionals to facilitate this training, right? But the interventions, actually not, because even our first one was facilitated only purely by Bhutanese community leaders after they went through this training. So they actually understand the trauma, and also they are very experienced community leaders. So I felt completely confident. I was just sitting in the back with the interpreter, but they just beautifully facilitated everything without any mental health providers involved. And also the community gardening, also we didn't have any mental health professionals. I was there, but I wasn't co-facilitator. Actually, facilitator, one person from community agency, and another person, actually we had 2 interpreters from the refugee community. So the leaders / interpreter co-facilitated together. So mental health professionals were not really needed because our contents were basically focusing on wellness. And actually, a beautiful thing happened after those interventions is that they kind of starting like asking more kind of help, asking for help. Like, I have this kind of problem, and then can I get some information about this? And then some of them was actually mental health. So.
Do you have data on some of the interventions? Because I know one thing that I'm really working on is trying to figure out how to measure the effectiveness of wellness interventions. And I just want to hear how you, kind of some of the things that you've explored when you're trying to measure the effectiveness of these interventions.
Yes, I can maybe spend an hour about that because, so as you can imagine, you know, sometimes people say, oh yeah, quantitative because the funders are looking for that number. But I couldn't really do much because depending on, again, the literacy level and understanding of the, you know, people's kind of the, you know, knowledge about the research itself. So I kind of tried actually this group, the women and Congolese, a lot of women actually are literate. So we tried, but wasn't quite successful. So we actually recorded everything. I recorded everything from the beginning of the meeting until the end of the session, like the entire session plus the focus group at the end. So I kind of transcribed everything and tried to find out what are the themes that I can find from this wellness, rather than using some top-down kind of approach, which oftentimes start with the factors or variables that you want to find. So I kind of let them just be, and then try to find a theme. So one of the themes were it's very interesting, but I couldn't really say that this is just the empowerment and just the problem solving. I needed a little bit more structure, so this is my preference, but I often use thematic analysis using some theory. So it's a kind of a hybrid thematic analysis. Sorry for the research terminology. I used some framework. So in this article, I actually mentioned the critical health literacy. It's not functional, which is a kind of knowledge-based, but the critical health literacy means that people are critically see and consume the information related to health access. So I use that kind of the different concept to analyze this one. And this one was actually from my peer-based intervention, the first one. And again, I also used the social capital as a framework to look at the findings. It's open-ended, it's a focus group, it's qualitative, but I still wanted to link those qualitative information with some of the current literature. So theoretical actually analysis kind of helped. And I didn't put here, but also I later actually found a good sort of kind of framework, which is a health capital. So health capital was actually 1970s concept, so it was really not very well used, but I kind of discovered, and then I thought that would be a good kind of framework to show the findings from this wellness workshop. So I had another article about the health capital as well. Yeah.
Thank you for this. I'm wondering if you can talk about like the next step after the wellness programming, if you have engagement, if you have support from community, and there are individuals that may come in and share with you privately that they are struggling, or that their family or their friend is struggling. What have been some successes that you have had or you've seen in terms of engaging people into that tier 3 or tier 4 support? You see they are suffering and they are struggling, but the stigma sometimes is pretty significant. And how do you overcome the shame and guilt to get them to treatment and to get them to there consistently? Because we see that.
Yeah, I mean, this is a really great, good question. So I was hearing your question. I had multiple answers in my head. So starting with your first part of question. So after the intervention, I've seen some beautiful kind of examples. For example, we taught through the training, the community members, about the listening skill, like a deep listening and active listening. But deep listening doesn't, involve much feedback, but it's more about listening and just being present and kind of being supportive to the person. So actually, one of the beautiful story was one participant. She had a brother who has some alcohol problem. So she actually. It was beautiful. Actually, she cried when she was sharing this story. She told me that something magical happened last week. I talked with my brother as usual, but I decided to use a deep listening skill. And after that, actually a week later, her brother came to her and said, "Thank you so much for listening. Maybe I should listen more to you." And then he actually signed up for AAA group after that. So I was like, oh, that's very touching. But coming to back to your second part of the question, the access to actual services, which is still, I feel, a little bit challenging. That's why I'm so empathizing the community-based program, because even providing these actually really help community a lot in terms of their own resilience and coping. We don't necessarily need to always just, seek treatment when someone is suffering because of some trauma-related symptoms. Of course, I'm not saying that you shouldn't go, but I think sometimes, a lot of times, people actually build a relationship in the community and get proper support from the community members. Then a lot of times they are actually getting much better and more willing to access to those services. So one example that I don't know if this maybe is not very encouraging, but so after this we built. So the Richmond, where I am at, we didn't have really, good resources for the trauma-focused intervention, Tier 3. We didn't have much. We have some individual practitioners, but we didn't have any torture survivor centers, and we didn't have much resources. But we finally made one, and we're so excited because, through this healing partnership, we create one, organization really working with dedicated to refugee population. There's a team, but the problem happened: people didn't go. So I think that is the very common challenge. That's why I always come back to the second part, like the community-based wellness and then intervention. So my next step, my dream, it didn't happen yet, but is after the wellness program, we provided more contents, more focused contents like a domestic violence group or substance abuse group, so that people actually can learn more about that and raise their self-awareness.
Okay, we've got three, I think, yes. Two. We've got two more, and then we're going to take a break. But before we take the break, I'm going to tell you where you're going after the break.
I have two questions. One, you mentioned that screening with the RSVP screener right when it first arrives may not be the most efficient time to do it. In your experience, is there a time that is the most efficient time?
I don't know if there is one, but so at least 30 days doesn't work. And also the questions are, so I don't know if you know the health screener, how it looks, but the 4 items, starting with, it's a PCPTSD, meaning the primary care PTSD item, so 4 items. And then there are anxiety and depression items from Hawkins symptom checklist. One of the items says actually, are you feeling blue? So I don't know how they actually interpreted that, but and then later there's a stress thermometer and things like that. So it's a very basic. So even those basic kind of screen, and somebody is a screen positive, maybe it's a very serious. What we try to do is so I don't know the Utah or Salt Lake City here, but in Virginia, the mental health screening is done in public health department. Some states or some location has their screening in the resettlement agencies when they have mental health providers, or sometimes they do in a primary clinic, which is ideal actually, so that refugees can come back. But we actually didn't have the integrated care yet for the refugee mental health, so it's been challenging to make them come back. So we try to move the location from the public health department to primary care clinic. So we can start still, we can do that because it's mandated and we can still ask them. But when they come back, we track them and then we kind of provide another screening after maybe 6 months or close to a year when they come back. So, but make them come back is not also easy, or tracking is not easy. So that kind of challenge we expect, but also still we can try again. So the screening, we just offer that once, but multiple times.
Thank you for very nice presentation and very informative information. I wonder, with your study, is there any correlation between people who suffer war trauma and their lifespan? Because from our agency's experience, we work with a lot of refugees, we find that there are a lot of people who die very early.
So the trauma and
Shortened lifespan.
oh, Mortality, okay, yes. So unfortunately, we didn't have much study done scientifically in the refugee population in specific. But I think the mortality, so AC study actually revealed that. So AC study showed that you know ACEs, right? Adverse childhood experiences is the #1 public health problem, including even mortality. So the early death, and people really think that there is some, kind of the biochemical sort of kind of relationship to that. I didn't have that kind of study, but I think one of the things that I can say is that depending on depending on the types of trauma too, certain kind of trauma actually, really change the people's functioning and coping. But certain types of trauma actually involves a physical injury, like a brain injury or just physical, the harms. So when I actually work with the Somali population, dying young is very common because of their risk behaviors and involvement in gang groups or community violence and crimes. So it's hard to say that is because of trauma, but that trauma really affected their behavioral, kind of the dangerous behaviors, and then that kind of lead to those mortality as well. So, which is slightly different from what ACEs study kind of talking about. But